quick legal disclaimer, all information in this podcast is the opinion of the speakers and not meant to be a substitute for a diagnosis and consultation of a qualified healthcare provider. Hey everyone, have you ever wondered about the latest advancements in TMJ treatment? Are there new surgical techniques or materials to help with these disorders? Join us today on Jaw Talk as we explore this topic and learn from expert cosmetic surgeon Dr. Reo Pugao, a highly experienced oral and maxillofacial surgeon from El Paso, Texas, who just happens to be my classmate from dental school. Dr. Pugao is a member of the High Desert Oral and Facial Surgery team, specializing in surgical treatments for the head and neck. He is affiliated with professional organizations such as the American Association of Oral and Maxillofacial Surgery, American Academy of Cosmetic Surgery, American College of Oral and Maxillofacial Surgeons, and American College of Surgeons. After working a few years as a medical technologist, Dr. Pugao earned his Doctor of Dental Surgery from Loma Linda University in 2007. In 2010, he received his Doctor of Medicine from Louisiana State University Health Sciences Center, School of Medicine, New Orleans. From there, he completed his postgraduate training in oral maxillofacial surgery at LSU, which included a general surgery internship certificate. I'm so excited to welcome Dr. Pugao. Let's jump right into the conversation.
Hey everybody, this is Dr. Tiffany from Team Deep Collective. I'm so excited to have on my podcast today Dr. Reo Pugao. He is a oral surgeon in West Texas, and he's also a former classmate of mine in dental school. So welcome to the show. Welcome to Draw Talk.
Thank you, Tiffany. It's been a long time. Thank you for the invite. I definitely tell everybody to stay tuned.
Awesome. Well, you were just talking a little bit before we got started here that I haven't really even heard, kind of your journey of like how you went from dental school to really oral surgery. So tell us a little bit about, how that.
Well, actually, it was anything profound. I actually was really the main reason is for me personally. I was halfway through dental school. I was kind of not happy just with general dentistry. Nothing, no offense to anybody. Hopefully I don't offend anybody or step anybody's foot.
Yeah, you can throw some shade here.
Right. Yeah, no, it's just, it was something like maybe there's something else to it. And it so happened to be my turn to rotate into oral surgery. And it just so happened they didn't have anything in the clinic and they sent me to the hospital, which I was like, what is going on? Why in the hospital? And sure enough, I saw my first jaw surgery and I was hooked since.
Where was that at?
It was at Loma Linda,
Okay.
at Loma Linda University at the hospital.
Okay, cool. Yeah.
Since then, I just asked the residents, hey, how do I go about getting into this program? And they helped me through it. And actually, our other classmate, Chris Morris.
Yeah.
Yeah, he was already set on going into oral maxillofacial surgery. And so I asked him, and he's been a good mentor and getting me into, helping me get into, know the ins and outs of it and getting into a program. So
nice. Well, did you end up seeing like a lot of trauma there?
So what you had to do is you end up having to visit other programs as what we call internships. And I visited San Antonio's and Vanderbilt's, and I actually spent some time with the residents in Loma Linda too. And yeah, you do see a lot of trauma. That's a lot of the bulk of what you're going to be seeing in the first few years of your residency until you get onto the more advanced stuff. So
yeah. Well, then like walk us through kind of like, how did you start doing, you were saying that like you got into practice and like you started to see like some gaps or like a real need for like people wanting to like operate on the joint, right?
Right. Well, so I trained after Loma Linda University, I matched into a 6-year program at Louisiana State University Health Sciences Center in New Orleans. And it's a dual degree program. In other words, during that time, you go to med school too, and you graduate also with an MD as well as your certificate in oral maxillofacial surgery. One of my co-residents there, he was 2 years ahead of me, noticed that there was a lack of service in El Paso. Yes, there were some ENT and oral surgeons too, and plastic surgeons, but a lot of them were doing the niche stuff, which is understandable. So we decided and we noticed a lot of the patients being sent out of El Paso. We decided to put a practice together and where the people of El Paso did not need to travel out and be referred out to metro areas like Dallas or San Antonio, and just have El Paso as its own provider for its people here in the surrounding areas. We, for example, we take facial trauma call for the whole city of El Paso and all southern half of New Mexico. We even get some from Arizona now too. So
Well, that could really range from a lot of different.
right, and just trauma in itself, it's as busy as it is. We're actually in a group of 7 docs now. It started out with just Dr. Vernon Burke and I, and Dr. Rebus back in the day. He's in Houston now, but now there's 7 of us, and we all have our own niche in different oral maxillofacial surgery scopes of practice. So we do see ourselves as a big scope of practice in the area. Our practice name is High Desert Oral Facial Surgery. And 2 of us are cleft and craniofacial trained fellows. And there are 2 of us also in the group that are head and neck cancer trained. So we provide a variety of cleft and craniofacial surgeries and also head and neck cancer with microvascular spears. And there are some of us like me who likes to do, for example, my niche is in facial cosmetic surgery and TMJ surgery. I know it's a broad range between the two, but we all still pull teeth and do dental implants for the most part too.
Yeah. Is there anyone in your group that's specifically operating on the TMJ, or are you the only one?
There are probably 2 of us mainly. All of us are trained in it.
Not everybody likes to do it though, right? Is that
It
true?
just depends, right? And because a lot of times we also get TMJ trauma like subcondylar fractures. We all know how to train. We all know how to treat it. We all see a certain amount of TMJ patients that we've all outed ourselves to. But I do see, like, I have my own TMJ consult clinic at least once a month where it's like 20 or 35 patients of just TMJ.
Yeah.
So,
Okay.
mhm.
Yeah. And then tell us a little bit about kind of like your decision process of like, how do you decide whether to do, maybe like conservative treatment, like you and I have talked about, kind of
Yeah.
my jam is like PT and injection therapy, whereas like, your jam is going to be maybe like orthocentesis or, obviously it depends on the condition of their joint talk us through kind of what that looks like.
Yeah. So even though we are surgeons, we like to cut, we still do believe in conservative therapy for a lot of TMJs. There's plenty of papers out there that still states if you leave the joint alone, and usually they do fine. Most of my practice ranges from teenagers to middle aged to older folks, usually ladies. The teenagers usually have more of, especially the females, have more of a myofascial myalgia component, a lot of clenchers, grinders, or as such. You only have 10% really who have some kind of a TMD kind of complex. The male patients, especially the teenagers, a lot of them, they do have more of a TMD component, but it's usually related more to trauma or something. Guys are a little bit more rough and to each
Right.
other kind of thing.
Pulling on their dirt bike or like skateboard.
Bites, studs, whatever, just something like that. Women here, they tend to chew more gum and they tend to clench and grind teeth more. So that's more myofascial and myalgia, such like that. So conservative therapy is perfect for that. You get into the middle age and upper geriatric categories of, let's say, 40s to 60s to 70s. Now you're talking about more advanced internal derangement of joint, osteoarthritis as such. And so you can talk about conservative therapy, and I usually start them out that way anyway. But interventions do tend to follow it afterwards. After physical therapy, after some kind of a splint therapy, or arthrocentesis or arthroscopy with Botox injections to the muscles or as such. But usually, again, everybody kind of almost just starts out with conservative therapy unless there's some obvious, like, for example, I had a 23-year-old patient come in with not sudden, but progressively worsening of anterior open bite. And she had an undiagnosed rheumatoid arthritis. So and then you can see the joints wear away. And that's one that's like, well, conservative therapy is not really going to do much. So we actually jumped into bilateral joint replacements with TMJ concepts. And she did fine. She's been doing good. She's 28 now, and she's doing still the same. Pretty good. Follow up every year and no complaints.
Most dentists get wrong about like TMJ surgery.
Yeah. So
I think there was like this whole thing, like there was like a lot of stuff that happened in the 80s where like, things went sideways or maybe there was like giant cell tumors or.
Okay. So I will tell you this much. Remember when I said I trained out in LSU, New Orleans, and
Yeah.
the chairman at the time was a man, but it was the still chairman when I was there, by the name of Jack Kent. And one of the prosthesis of TMJ surgeons at the time were the Kent Vitek system, and it was made out of Teflon. And what was happening is over time, people were starting having a granulation reaction, a giant cell reaction to these things. So I wasn't there, but I'm kind of there because my chairman was the one that kind of put these in, and he noticed that that's what was happening right away and had it taken out. So I think a lot of that materials is what kind of gave TMJ surgery a bad name. And then not so much the people. I mean, everybody was trying to do all sorts of materials to place in the joint, see which one works well. And this was, if it weren't for those, I guess, if it weren't for those kind of surgeries, and not just with LSU, but also with other programs, we wouldn't have what we have now, a really good protocol in how to treat them as such. So yeah, it did get a bad rep just because of that. Obviously, it was corrected as soon as it was caught for a lot of people, maybe not so much for others patients, but because of that, we learned that, yeah, it's not a good idea to do those things and go back to conservative therapy. And then other systems came out. For example, in the 80s too, where arthroscopy was just coming about in 85 with Onishi in Japan. Well, they were using a regular TV to see it, but they could see, but it's just not at the clarity that we have now. Now we can see individual red blood cells going through the capillaries of the joints in the capsule. So you can actually tell which one is actually inflamed and how extensive the scar tissue is just by the clarity of the scopes nowadays. And there are programs, especially when I say Nova with Dr. McCain, he has fellowship training provide fellowship training for those who want to do surgeries just with the scope. This plication, discectomies through a small, like 1.9 to 2 millimeter hole. And so those have gotten advanced since then. There are only two FDA recognized joint prosthesis in the country. There is TMJ Concepts out in Ventura, California, where it's custom made. Yeah, you remember how you had to wax up crowns and then cast it in gold? Same thing with these, basically. They wax them up. They send it, you get a scan, you send a scan over and they wax up the model. You cut off the joint and then they wax up a prosthetic to that.
Wow.
And then you approve
Are they
it with
doing that off of like CBCT or like MRI imaging or what?
cone beam CT. Initially, when they first started, they preferred only medical grade CT, but now a lot of that has adapted to cone beam CT as well. And the other joint replacement is a stock joint by Biomed. And what it is, basically, it comes in small, medium, large, and their measurements are for like 45 millimeters, 50, 55. And you just measure the size of the joint according to your jaw, and then that's what you have to replace. And the fossa is also replaced. The TMJ Concepts has a cast titanium that sits on the bone with a high polymer plastic fused to it, whereas the stock joint, Biomed, has just a whole polymer plastic, high polymer plastic that is the fossa. So if you see some of these post-op imaging of these joints, you can see a gap where the head of the joint is to the bone, but that's because there's a layer of plastic there that it sits on as such.
So like
And
what would you say is like your favorite piece of tech that like you can't live without?
we've had, before the advent of these, there's documented literature of people using the toe as a joint replacement or growing one, using distraction or using rib. I was in that gray zone where we were still using ribs as joint before the transition into like joint prosthetic. So, or fibula, grabbing the fibular bone and taking it up there. So could I live with one out of the other? Possibly, just because I've been trained in harvesting rib. But at the same time, the difference between the two is one, you have almost like a 4-month wait or 3-month wait because you have to, it's custom made and it's still what you call waxed up. Whereas now there's digital printing. Who knows? They may turn that way, but we'll see. But the stock joints are easily can be placed and it's readily available. So nowadays I'm probably spoiled more with the stock joint.
What's like the longevity of that type of replacement?
Yeah, no, that's a good question. Actually, we've had some place for, well, let's just say when I was training, starting in 2007 with TMJ Concepts, I could follow with a lot of the other docs or the TMJ gurus like Dr. Wolfer and Dr. Miloro and them also and Ken and I'll tell you this much, they haven't, I don't think they've replaced any unless it was loose, infected, or some kind of a uh,
Complicated.
faulty thing, which is very rare. We've had really good results in the past 20 years of just the longevity wise and functionality, return to functionality without the issue of any adverse events.
Yeah. Who's like the West Coast guru?
Yeah, well, there's quite a few of them out there too. You could always say like, Hereford does a lot of, he could do a lot of these comfortably. I don't think he would be one. A lot of other guys would name us the TMJ guru as such. I'm a little bit more familiar with the East guys because that's where I've done more training with, like Spagnoli and them. But there's quite a few in the Seattle area. I'm not sure, but oh no, well I do. I do know Sam Bobek. Actually, Sam Bobek was a colleague of mine who's training with me. He was a fellow at the time at Charlotte, and I know he does quite a few joints.
Yeah. So, like Guillermo Chacon is probably like the only one kind of in my area that will even do like arthrocentesis and
He's one of our well-known surgeons in our field. He's been part of the board. He's done a lot of review lectures, so he's a good
yeah,
he's
he's
a good surgeon too.
fantastic. I love
Yeah,
him.
like I
He's
said, I've never met him, but
yeah,
I know of him. So
yeah, yeah. Well, and that's the funny thing is like, your oral surgeons, like there's not very many of you, right?
I would say maybe around 8,000, I think. And we always go to our favorite associate societies meetings, the AMIS, or I go mostly to ACOMS. ACOMS is, to me personally, is the little brother of AMIS or little sister, but it's the same people. It's just more education geared for those 3 days. It's more concentrated. It has a lot more cosmetics for
Yeah.
my taste. And there's a lot of guys out there. So in my practice, we're kind of a hybrid practice. We're not just typical oral surgeons doing teeth and implants. We
Mhm.
actually take call and on a regular basis and actually operate on a regular basis. We're in the hospital, we're in the OR at least 2 or 3 times a week, each of us individually. We cover a lot of hospitals in the El Paso area and again, service a lot of southern New Mexico too. And I say southern because there's the only other surgeons close by are the Albuquerque guys. There's one of us in Las Cruces, but he's doing his typical oral surgery stuff, and sends us a lot of the medical head neck stuff. So in that regard, we go to these associate meetings. We know a lot of, just talk with a lot of these colleagues that know the same thing and does the same thing that we do. It's actually quite a few of us. But there's also help with Texas Tech with the dental school here now too, and the University Medical Center aligning with them as a level 1 facial trauma service. So that's why we have 2 fellowship training programs in head and neck cancer and cleft and craniofacial. So we're a big group
Yeah.
in hybrid in a way. So
That's awesome. Like, what advice would you give to like a young dentist that was maybe wanting to go into oral surgery?
oh well, I'll tell you this much. It's those who are going in oral surgery are either because they knew somebody of that specialty and that's why they went into dental school, or there are those like me who realize halfway through it that this is what they want to do. I would say, you know, practice reading a lot, I guess. No, really, it's just, just be patient. Be patient. It's a long road ahead.
It's a long
It's a long road
process.
ahead. And while you're there in training, absorb as much as you can because once you're out, there's nobody going to be looking over your shoulders. I'll tell you that much. Even in dentistry, learn as much as you can while you're in school because
Yeah.
once you're on your own, that's it. You
Well,
can
and
always
that's why I think, like mentorship is so important too. I think that, kind of building, your groups that you're collaborating with. And I think that's an amazing way to kind of help your skills and just keep pushing you forward.
yeah.
Sure. Yeah. Yeah. Cool. So I was just gonna also ask you, like, what are your thoughts about there's like a lot of like interceptive ortho being done on like young kids, where that paradigm is like kind of shifting where we're learning more about airway, kind of, instead of like waiting with ortho, it's, getting kiddos in sometimes like 4 to 7 year olds and just starting to like kind of look at that craniofacial growth and see, if we can intervene, let's say for airway space or expansion. What are your thoughts about that?
Well, the bone is at that age is definitely much more pliable and
Viable.
stuff, and it does in a way kind of mend to easier treatments. Let's say orthodontically, or if there's any way you could do conservative treatment to help someone's functionality, either by breathing or bite, it doesn't hurt. To me personally, I'm not sure how much the literature really is in support or such. I couldn't really give you off the top of my head what are some good evidence-based kind of literature on that. I'm more of the camp of did the malocclusion cause the TMJ issues?
Bad joints or bad bite?
Are the joys bound by that? Well, I still see them separately. But if there was, let's say, a stable bite before, depending whether it was a class 2 or 3, and now it's changed,
Changing.
then there may be a suspicion of, like, let's say, an anterior open bite or posterior cross bite. Is it because of the joint that's an issue? Is there some kind of level of arthritis or absorption as such? But there's, in, the surgeon's mentality of the literature is that, the occlusion and collaboration may or may not really be helpful in terms of relationship to it.
Well, and my thing is like now that we have, more modern imaging that's accessible, if you do have, let's say, that young female, maybe she's like, 8 to 10, maybe she's like fallen off a rope swing or like had a gymnastic injury or like, kind of like a series of different things. And then you're starting to kind of see that anterior open bite. Maybe she's got some hypermobility, maybe connective tissue, disorders. Like I think that as dentists, we're like scared to do like more advanced imaging if there's not paid, especially like MRI. So like in my own kiddo, he's 11 now and he had like a series of things like that where it was like, fall on the chin at age 3. And then like in kindergarten, another fall. And then like 1 month later, another fall. And, so starting to see those bite changes and, kind of like short ramus height on one side. One side doesn't seem like it's growing to like the same level as the other side, so differences in maxilla and, mandibular projection. So, just getting him scanned was like a major barrier, and, turns off, that short side has more degrees of displacement. So we can still recapture if we get him into like a functional brace that brings him forward. But I just think like not a lot of dentists are willing to like really push forward with like imaging, especially in, a kid that doesn't have a case.
So yeah, I mean, imaging, especially MRIs, they're expensive. The upside to it is there's no radiation. It's really just magnetism.
Yeah.
The problem with growth, and this is just with facial growth, is it's really hard to predict where that growth is going. You're always constantly growing no matter what. I mean, right now here we are sitting, we're past our adolescence, which is where the most of our
Now
growth
we're
comes from.
degenerating.
Well, we're degenerating, but our face is still just growing. We're going to grow a bigger chin, a longer chin, or a bigger nose and a longer nose. That's the destiny we have. I mean, if you have a picture of you back in your 20s and you take a picture of yourself now, you'll notice like, oh my goodness, my nose looks bigger or something.
Well, my chin's like this way because
yeah.
a bunch of car accidents, and then I got my TM joint scanned yesterday, and I was like, sure enough, it's the right side. The disc is like
right. I mean,
I knew it.
We do treat a complex of especially in adolescents, like, hyperplasia of the joint versus hypoplasia. Which one's first? How do you measure it? How do you decide which joint to treat? Or do you just let it burn out and then do jaw surgery, orthodontic surgery? There's definitely a lot of camps who advocate for that.
And
There's
I
a
just don't like
guy.
that. I'm
Yeah,
like,
I mean,
why do we like let it get so bad? I mean, it's like if it was your knee and you're like a ski racer, you wouldn't be like, oh, well, just don't go up and down stairs for the next 15 years until we replace your joint.
I see what you're saying. The problem is if you go into something like an inflamed, let's say an inflamed joint, and we'll just refer back to the joint itself, an inflamed joint right away and do something to it. We definitely know literature-wise the outcomes are just not as good. The results are not as you end up having to do a second surgery sometimes. For example, a good example would be somebody with a class 2 bite and there's some kind of evidence of joint degeneration during their teenager years. And you do jaw surgery on them to advance the lower jaw forward to get into a more class 1 occlusion. Well, the joints are not done burning. So guess what? Now you're back to a class 2 bite again. And then you have to do another surgery to elongate it or now you're talking about joint replacement because you can only advance the lower jaw for so much, such. And that's part of the reason. It's really hard to predict. And and one thing I know about for sure in TMJ, the more we know about it, the less we actually understand it. But definitely since the 80s, there's been a lot of good literature in terms of leaving it alone, just do conservative therapy and see what it does, and then intervene once it burns out. It's not like having a hot tooth and an abscess. It's an abscess, take the tooth out. Don't wait for it to sit there and let it see what it does. But joints are a bit different, and only because some of the things that you do intervene with, it's a big surgery, and then years down the line, you find out you end up having to do another surgery just because of the continuation of the pathology of the process of that joint.
Yeah.
And going back, one thing I've found with teenager females, I'll say, they come into the office, they go through the screening questions. I ask them, is it the joint or is it the musculoskeletal system? And a lot of times it's musculoskeletal. Yeah, they chew gum, they grind their teeth, or they grind their teeth at night. They don't know, and they yawn, and it hurts. A lot of them just end up having like conservative therapy. I put them on Robaxin and meloxicam, see how they do for 2 weeks with a soft diet, warm compress. And then after 2 weeks, then I take them off the medication to see if they're medication dependent. And in 2 weeks, they let me know, oh, I'm actually doing better, or no, I'm not. I need to get back into meds. All right, then let's see for physical therapy and splint therapy. And then after physical therapy, then they let me know, oh, I'm actually doing good, but maybe I'll just keep them the meds. Or now they know how to take care of themselves conservatively because they know that may happen again. And then splint wise, I just put them on it for 2 weeks straight and see how they do, and then take them off of it another 2 weeks and just have them wear it at night to see if they're split dependent or not. And then it gets to a point, let's say I'm still having muscle issues. I mean, I still can't open wide. It still hurts. Then that's when Botox for me comes in and Kenalog. I don't know if you do. I do Kenalog injections with marking to the temporalis tendon, have them open wide in a coronoid process and just find the crunchiness of the temporalis tendon attached to it and inject Kenalog and mixture of Kenalog and marking in the area for a total 1 cc on each side. And that helps them out a lot. So,
Yeah. And then like what kind of like how did you find the physical therapist that you work with? Like did you kind of like I think sometimes it's hard to kind of like find your people that like do what you want.
so going back a little bit, our practice is a payer mix of Medicaid and obviously private insurance. And surprisingly enough, there's 2 separate physical therapy, one for that doesn't see Medicaid and the other one sees Medicaid. And they've all had pretty good results back to me in terms of biomechanic feedback, jaw motion exercises. And I've had some really good feedback from the patients and such. Coming back and say, hey, that really helped me out a lot. And I wish I could do more. I said, okay, go ahead and just keep going at you if you want. That's it. Or the physical therapist will recommend another 6 to 8 weeks of treatment. It's only the ones that come back and say, you know what, I wish I could, it's not really helping or I'm still tight. Then that's when Botox come in. Or sometimes after even ultrasound therapy by the physical therapist, they'll send them back saying, you know what, I think they're time for Botox. So they came out to seek us, actually. We never really had to seek them. So we've been fortunate.
That's awesome. Yeah. Yeah. And I think that's where, I'm kind of trying to like bring in some of like my physical therapy because I'm seeing a lot of like oral myofunctional therapists that are like speech language and their PTs and their OTs, and like they're already like really excited about, like kind of working together. And, they may have a little bit different lens of looking at things than, a dentist is going to be obviously like focused on the occlusion and, all of those things. And they're going to be kind of coming at it from a different way. And I think it's great when we can all collaborate and
Mhm.
be quite so siloed into our specialty. So
And I do get excited when a general dentist has TMJ experience in terms of maintenance or splint therapy and I have to be very critical of it. I have to ask them, did they do some kind of graduate training, postgraduate training, like a GPR or something like that? Or did they do just one weekend course and suddenly they're TMJ experts? Something.
well,
And
what do you see?
probably went around that. Well, we have a few who's actually did like a TMJ fellowship and did who knows how long it was, but I know it wasn't a weekend course thing. But I do trust that their patients sometimes, if another general dentist doesn't want to take care of TMJ medically or conservatively, then I recommend them to take care of it. So it's really helpful. I
Yeah.
still do end up having to do a lot of that, which is fine. Is you monitor them, and it's kind of interesting how they, I've had some that came in here when they were 12, not necessarily for TMD, but for myalgia, and now they're this, older, and now they have clicking. I was like, that's new. So now we're just watching it and see if clicking's fine, but it's moving fine. Will it become a pop, or now clicking's gone and they can't open as wide anymore?
Right. Now
Something.
they're got a closed lock.
Mhm, mhm.
Yeah.
And sometimes it gets to a point where, and this is something I actually like to do in the office. Now, I don't know how many maxillofacial guys do this, but sometimes it's hard to tell whether it's the joint or the muscle itself. And I actually end up having to do a diagnostic injection on them. And I just go from a pre-auricular approach and just a 27 gauge needle, clean out the skin and do a auriculotemporal block.
Yeah.
And,
My
whether
study
it's the
club,
needle.
we're like practicing that too. It's still like, it's pretty like, I don't know. It's still a little scary. Like bury that.
Yeah, no, I mean, I do that often in practice now,
Mhm.
and you actually can easily determine, and sometimes the patients don't believe it themselves that, oh, it can't be my joint or it can't be my muscle or something, and you give them their auriculotemporal block, and suddenly you have them sit there for a while after sedation one, and they're like, oh, the
Yeah.
pain is gone.
Yeah.
Yeah, so it's your joint, I mean. So now you're dealing with joint or myofascial. I mean, a lot of times you're dealing with a little bit of both. So, a lot of times when I take them back for arthroscopy, I do scopes and I do arthrocentesis. I do mostly scopes. I take them back and sometimes I'll laser and such, but they all get Botox and canalog and marcaine injection to the musculoskeletal system anyway. I don't
Mhm.
just treat the joint itself. I just treat the whole complex component of it.
Yeah. Yeah. No, we've been learning like greater auricular and then like greater occipital blocks as well. It's
Hmm.
just, it's a way of like diagnostically trying to kind of like pin down the layers of pain and figure out where it's coming from.
Yeah.
Yeah, that's awesome.
And for any dentist who's listening to this episode, as such, I mean, you won't hear the surgeon say it, but if you can learn to inject Botox to the masseter and temporalis muscles, why not? Especially if you're seeing those kind of patients, just know the criteria as such and know your limits. But why not go at it?
Yeah, I think it's a really important tool, but I would say I think as general dentists, we need to like slow down and get better with our diagnosis, though. I think that we didn't really get taught that much in dentist school about the TM joint. I mean, do you remember? I mean, I think we got like 2 days of it and it seemed like
Well, I
it.
mean, we got more on occlusion than we did on TMJs.
Totally, totally. Yeah.
Yes.
And then
And
everyone was like bored. They're like, I don't want to go. Like, all she's doing is like spray and stretch and like appliances. Like, I just want to get back on the clinic floor.
well, when I started residency and there was already that stigma of TMJ patients, they're so needy, they're all this. And now look at me, I'm seeing facial cosmetic patients and TMJ, and they're both like the most extreme on both sides of the spectrum. I think they're both the same patient, really, for the most part. But
Why do you
and
think
same thing
that?
Well, same thing in residency. It's some residencies do train, and so you're supposed to be trained the same in TMJ assessment and treatments, but some residencies are different. Some shy away from it and just say, no, just keep it closed, treat it closed, or so. And there's good literature to support that, but they're never really competent to come out and open a joint if it needed to be. Whereas other programs are much more competent in that. And that's just something that we also have to work on as a profession, as a specialty, that, there's really nobody else treating joints except
Yeah.
the dental community itself and oral maxillofacial guys who have to intervene. We're it. I mean, ENT doesn't even though they do a lot of prerequisite approaches, doesn't do that. And even though ENT was the first one to say that there was some kind of maybe a relationship with malocclusion and TMJ back in, I think it was the Costin syndrome, if I remember right. But it's still something that we need to do as a profession, is just being able. And I tell you this much, I was during residency, I was like, I'm private practice, I am not going to see TMJ patients.
And here you are.
Here I am.
Now
And
you're
I owe that,
in-
well, I owe that to a lot to my mentors, and Dr. Jack Can and Dan Spagnoli, who and the late Randolph Malloy, who weren't afraid to treat a joint, to and open it up and do something to it. That, and it really helped out quite a lot of patients, and it made me understand that there are components to it that once you diagnose it properly, you can actually treat it just fine. And a lot of these patients are not as needy as you think they are, or the mantra of that crazy patient.
Well, and like I said, I think when we start to recognize, more of like how all of these things are related with like sleep and airway and, all of the like musculoskeletal system, it's like, yeah, they're not crazy. They have like legitimate things that you start to see with better imaging techniques and better, like I said, diagnostic techniques. So,
Yeah, and there's always that initial myth of, oh, they're just drug seeking. In a sense, I've never had one TMJ patient ask for hydrocodone or ask for some kind of narcotic. Well, I'm allergic to that. They've all been having some kind of a myofascial, genuine myofascial or TMJ pain. And once you figure out which one to treat, and this goes for any dentist who's listening, once you figure out which one to treat, it's not really that hard to figure out. Just, having said that, no general dentist, please try not to do an arthrocentesis in the office. That's
arrange your oral surgeon in your area. Well, I was telling you, I'd been hearing like from UCI, their podcasts on TMJ treatment, and they're talking about like a neocartilage implant called the Hyaluronic. Just like, I'd love to hear like, what do you feel like is like coming down the pipe that's like exciting as far as like new surgical techniques or new materials?
Yeah, no, I mean, I haven't heard much about it. I'll tell you this much. I know there have been works of like trying to, especially with the advent of new biomedical research, could you, like when BMP was all about, everybody was raving about bone genetic protein, could somebody make a cartilage or to create as a new fossa or as a new cartilage for the joint? For a while there was there's still another TMJ company called Nexus, where they had a metal fossa that sit on bone. And I'll tell you this much, I've never placed one. I've heard a lot of colleagues who placed them, and patients have never had any issues. But you do have, just like, you picture that scene in Braveheart where you have Wisconsin, the English, and they're all going at it. That's how TMJ controversies are. They're always going to be that way for a while. And it got all taken off the market because you had the older guru saying like, you shouldn't be putting metal on bone like that. So it stopped, and they have, more pull with the FDA as such right now, and who knows? And that's why maybe cartilage will be the next thing. I mean, we've done grafting with auricular cartilage or just fat, and they end up just being fibrosed or cracked, or actually plenty of literature to say that you don't have to put anything between there. Just let it.
Does the fat stay viable, or does it?
No, it turns into scar tissue eventually, but there's plenty of literature saying that you don't have to put anything in there once you take the disc out. Just leave it alone. Yeah, the patients might hear some grinding of the bone, but
Ankylosis
or it may have ankylosis, but if you have good physical therapy and such, you keep functioning fine. You shouldn't have that issue.
yeah. Super cool. Well, tell our listeners like where they can find you if they want to like
Oh,
venture into West Texas.
well, again, like I said, I mean, any one of us could treat TMJs. It's one of our scopes that we're all trained to do in residency, just like trauma or orthodontic surgery and stuff. But we're here in El Paso, Texas, high desert oral facial surgery. Again, any one of us are quite comfortable doing that.
Awesome. Awesome. Or we'll put all of those links in our show notes. And thank you so much for being on our show, Jaw Talk with Dr. Tiffany. It's just been like such an honor. You know, you were one of my favorite back row people in dental school. Like we were like the ones that were like playing little games like Jawbreaker and like telling like the people on the front row to shut up and like stop talking.
I know. Thank goodness we did learn something, or else we wouldn't be here in this point.
So great.
But thank you for the invite, and it's been an honor, Dr.
Oh,
Tiffany.
yeah.
Thank
No,
you.
it's an honor
Thank you
to
so much.
have you. Thank you so much.
Thanks for tuning in today to Jaw Talk with Dr. Tiffany. We hope you're feeling more informed and empowered to seek out relief from TMJ disorders by exploring the latest surgical innovations for treatment. Until next time, keep talking about TMJ health and stay curious.